Welcome to our lecture on routine problems of pregnancy. Let's get started. And when I say routine problems of pregnancy, I'm referring to some of those problems that are just inconvenient for the patient. They're not necessarily going to kill them. And these are the issues that we're going to go through: back pain, constipation, GERD, hemorrhoids, pica, urinary frequency, and varicose veins. So let's start with back pain. Now, back pain during pregnancy has several mechanisms. Like, there's several reasons why this can occur. So first, there's an enlarged uterus, and that can actually cause exaggerated lordosis, so that curvature of the spine. Secondly, there's an increased ligament laxity from the high progesterone level. And third, there's stretch and weakening of abdominal muscles, so that actually further decreases the lumbar support. So if you got this enlarging uterus, exaggerated lordosis, it's more lax because of progesterone, and even the abdominal muscles aren't helping. Now, the risk factors for back pain in pregnancy include excessive weight gain and chronic back pain before pregnancy. So that kind of makes sense. If they had back problems before pregnancy, then they have a higher chance of having back problems during pregnancy. Now, imaging is typically not indicated because this pregnancy-induced back pain is benign. But with all things, if there's a red flag symptom, for example, you're worried about a spinal cord compression or aortic dissection or cancer in the spine, then you're going to want to get imaging. But for this, there's no red flags. You expect it to happen in pregnancy. Many women complain of this. You do not need to image. Now, how do you treat it? How do you help your patient? Well, what you do is you can give heating pads and analgesics. Basically, you're just treating the symptoms. There's nothing you are planning on doing to really prevent it. They're pregnant. That's going to happen. But help heat it, make it more comfortable, reduce the pain. So now let's talk about constipation and gastroesophageal reflux disease, or GERD. So constipation and GERD are caused by progesterone and relaxin-mediated smooth muscle relaxation, and that specifically in the GI tract. Now, constipation is usually treated with increased fiber and increased water intake, but it can actually be severe enough that you're going to want to give your patient some laxatives. So as you can see, you're treating this constipation in pregnancy very similar to how you treat constipation with somebody who wasn't pregnant. Now, as we already said, the mechanism of GERD in pregnancy is the same as that of constipation. So there's progesterone, smooth muscle relaxation of the GI tract. So what you're going to do for these patients is give them antacids and proton pump inhibitors. So again, that's not any different than what you do with patients outside of pregnancy. Now let's talk about hemorrhoids. So hemorrhoids during pregnancy are caused by increased pressure on the anorectal venous system. And so there's this protrusion of mucosal veins. And hemorrhoids are usually treated with increased fiber and water intake, very similar to how you treat the constipation. But you'd also recommend sitz baths and even a hemorrhoidectomy. But that you would only do in severe cases. So now let's move on to pica. So pica is characterized by craving and eating of non-food substances like hair, ice, dirt, and paint chips. So up to this point, we've discussed routine problems of pregnancy that are pretty typical of people that aren't pregnant. But now we're approaching pica. Pica is kind of weird. So what you do here for your pregnant patient is you just treat it with psychotherapy and nutritional rehabilitation, typically done via iron supplementation. So you want to give them iron, help their nutrition, help them less likely to crave weird things, but then treat their psychiatric issue. And you do that with psychotherapy, but you can do it with SSRIs. So if you're not controlling it with the other two things, consider medicating the patient. Now let's talk about urinary frequency. So urinary frequency during pregnancy is one of the most expected things to happen in pregnancy because you've got this expanding uterus, and that naturally puts pressure on the bladder. And the treatment for this is usually supportive. So you help the patient relax, and you're helping them cope with that increased frequency because there's not a whole lot you can do about that extra pressure on the bladder until you get rid of that baby. So you just have to go through childbirth and get rid of it, and then their bladder can have the normal space that it typically has. Now, antimuscarinic agents like tolterodine, sulfenacin can be used, but it's rarely used during pregnancy. And that's because these medications can exacerbate pregnancy-induced smooth muscle relaxation. And as we've said before, that smooth muscle relaxation is a problem that causes GERD and constipation. You don't want those side effects unless you really need to. So again, you're just trying to support this patient through it. Now let's talk about varicose veins. These occur due to the inferior vena cava being compressed by the gravid uterus, and the resultant backflow of blood then goes into the superficial veins, and you see these varicose veins. So how do you treat these? Well, you just put compression stockings on, and you can actually even elevate the legs You'll recommend this for your patient because that leg elevation will help force the blood to more proximal parts of the body. So it's not just pooling and putting pressure down there in the superficial veins. So compression stockings, leg elevation. Now let's wrap up with a question. A 31-year-old G2P1 female comes to the physician at 25 weeks gestation for a routine prenatal visit. Her previous pregnancy was uncomplicated. She complains of sour taste in her mouth, which gets worse when she lies down. This taste disrupts her sleep. What is the mechanism of this patient's complaint? So feel free to pause the video so you can think about this answer. Okay, so the patient complains of a sour taste that's worse when she lies down. So that's consistent with GERD. And you may recall from earlier in our discussion that during pregnancy, progesterone and relaxin will actually decrease that lower esophageal sphincter tone. And with that loss of tone, there's more acid reflux. So that's the reason why these patients get GERD during pregnancy. So it's hormonal and then a decrease in GI tone, including the lower esophageal sphincter. During pregnancy, progesterone and relaxin decrease lower esophageal sphincter tone.